Welcome back to the Emergency Medicine channel of Amrita Institute of Medical Sciences. I'm Vishaka Kiranjiji, fourth year MBBS student, here to present a video demonstration on management of severe acute asthma under the guidance of Dr. Girish sir and the Emergency Medicine Department.
Can we start now?
Yes, sir.
Okay. So we have a clinical scenario like this. This is a young male patient coming to emergency medicine department with severe breathlessness. He's a non-asthmatic patient. He had past history of asthma, but now he has arrived with severe breathlessness. Okay. So what all vitals you want me to tell, you can ask. Patient has come with severe breathlessness. That is a first.
Please connect the monitor. Sir, what is the respiratory rate?
Respiratory rate is 32 breaths per minute.
Heart rate?
Heart rate is 88 beats. It is normal.
BP?
BP is 130 by 85. He is not an hypertensive patient.
Saturation?
Oxygen saturation, please connect to the monitor. It is 88% in room air. We have not started any oxygen.
Temperature?
Temperature is 37 degrees Celsius.
His GCS?
GCS is normal. He is alert. He is conscious. He is able to talk, but with difficulty.
I will be auscultating the patient.
Okay. So he has got bilateral extensive V's. Saturation is 88%.
Nurse, please start the high flow non-rebreather mask. Please also connect two large bore IV cannulas.
So you put IV cannulation. Please come here, this side. We start IV cannulation. So propped up position is kept.
Two large bore IV cannulas secured.
Okay. So we have started rebreather mask. How much oxygen is set?
Up to 94 to 98% of saturation. You can maintain that up to 1 hour.
Okay. So you give 9 liters of oxygen to be connected.
9 liters set. Also, maintain the propped up position. Now, please start his GCS normal, his no circulatory shock. So please start nebulization. Salbutamol 5 mg along with ipratropium bromide 0.5 mg for around 20 repeat the cycle for 3 times for every 20.
So we start nebulization now with salbutamol ipratropium combination for 20 minutes. You give that. You want to know anything else? After we have started nebulization now.
Also start give him IV 100 mg of hydrocortisone.
You can give hydrocortisone. Give to him.
Hydrocortisone 100 mg.
Reassessing the V's.
Okay. This is still persisting.
Please give 2 mg IV magnesium sulfate.
You give 2 gram magnesium sulfate infusion.
2 gram magnesium sulfate given.
Reassessing the patient.
Still VC is persisting.
Please immediately start BiPAP. Okay.
So start BiPAP. So she'll start BiPAP. Meanwhile, you want to do anything else?
I would like to take the patient's history. Have you, sir, have you had any recent events, any infections?
He had recent infection. He had a recent upper respiratory tract infection 3 days back. His family members also got same complaint.
So were you admitted in the ICU or intubated for the same any asthma cause?
No, he never had any intubation. Was not admitted in ICU. He's first time coming to hospital, but he had a history of fever last 3 days.
Have you ever been diagnosed with asthma or
He's
taking?
a non-asthmatic patient. He was on meter dose inhalers, but now last many months he is not using that.
Thank you. Nurse, please also send for ABG, CBC, chest X-ray, and ECG.
ABG shows type 1 respiratory failure. ECG shows tachycardia, sinus tachycardia. Chest X-ray shows normal chest X-ray with inflated lungs.
So This is a case of asthma.
Asthma.
And we have been treating him for asthma. I'll
Okay.
reassess the patient since
Okay,
BiPAP
reassess.
is given.
Okay. Now you want to know the vitals now? Repeat vitals.
Yes, sir.
Respiratory rate is 25. Heart rate is 90. Blood pressure is 130, 80 only. There is no change. Saturation is maintained above 94, 95. Temperature is normal. GCS is full.
The patient seems to have clinically improved.
Okay.
All his vitals are normal.
Okay.
What about his ABG results?
ABG shows type 1 respiratory failure, first one. Now we have to take second one. We'll inform you soon.
And the patient seems less distressed right now.
Okay.
He's more comfortable.
Okay.
Continue the medication up to 3 cycles.
Okay. So
along
give
with the BiPAP.
salbutamol nebulization 2 more cycles.
Okay.
Now.
Along with the BiPAP until the patient's ready and better.
Okay.
Then hydrocortisone can be stopped and you can start oral prednisone.
Okay. How much?
42.
40 milligram.
40.
You start 40 milligram hydrocortisone tablet. Okay. So you understood the case, how you are managing, you understood. That is a normal way we manage in emergency room. But there are some basic mistakes done. That is immediately, what is the first step? You propped up the patient. You told propped up as a third or fourth. That should not happen. Immediately we have to prop up the patient. That is very important. Second thing, you repeated the cycle of nebulization after BiPAP. Should have done it much before that. Because salbutamol, first cycle you had given, then you started BiPAP. Okay, BiPAP can be done. Along with you should have given nebulization. That's why patient has improvement has slightly delayed. Okay. Now can you tell me about asthma a little bit?
So asthma is a chronic reversible form of lung disease where you have bronchoconstriction.
Okay.
In this, symptoms that you see is cough, wheeze. It is mostly episodic.
Okay. So this patient, what do you think? What was the trigger for this patient?
So his recent history of infections might have triggered the asthma.
Okay. So should we treat this patient with antibiotic?
If the blood results come with a CRP high,
Blood result, CRP is very high. CBC is normal. Counts are normal. Procalcitonin is normal. What do you suspect?
treat for asthma.
Asthma. He had family history of same symptoms. He had upper respiratory tract infection symptoms. Now he is having asthma. Do you want to treat again?
No, not with antibiotics.
So what happens in a patient like this type of symptoms? What is a usual problem is viral infections, H1N1 or COVID. Okay, because I had given a history of family history had similar complaint. He had URTI symptoms. Both the things points towards a viral infection. Okay, so you can start if you want. If you wish, you can start oseltamivir. You know what is oseltamivir?
It is an antiviral drug.
Antiviral drug used for H1N1. So what is the dose? 75 milligram BD. That is a dose. Okay, so that can be given. Suppose your counts are very high, that WBC counts are very high, and procalcitonin is high. There is a chance of bacterial infection. So in that case, what antibiotic you want to prefer?
First, I'll start with broad spectrum antibiotics until the culture reports, sputum culture reports.
Okay, that's okay. Now we'll discuss about asthma. You told it's an episodic, and the trigger here was infection. Okay. Now this patient was on meter dose inhalers. He was taking salbutamol meter dose inhaler. Can we use that? Suppose he develops breathing difficulty at home. Can we use that drug for a acute episode? Is it possible?
Yes, sir. It is a short-acting beta-2 agonist, so you can use.
So it can be tried. Suppose he is having that drug, it can be tried. Okay. Now we have started NIV. That is NIV is BiPAP. She has started. The sister has started NIV. What are the contraindications for NIV in asthma? You know, contraindication.
No, sir.
So if the patient is unconscious, that is the most important conscious problem. Unconscious, never try this. And suppose you suspect pneumothorax. You know, pneumothorax can be most of the time mimic acute asthma. There also you should never use it. What are the mimickers of acute severe asthma? Mimickers. What are the conditions where you get acute breathlessness? It's a young patient, who you are not suspecting cardiac disease, you are not suspecting smoking induced disease.
Foreign body obstruction,
For a young child means foreign body obstruction. Then
pneumonia,
can be not acute, it can be slightly like it may take 2-3 days.
severe allergies,
What is it called as? Anaphylaxis. Anaphylaxis. What you told is correct, but it is more better name is anaphylaxis. Then elderly individuals, cardiac failure. Okay. So there is some concept called as cardiac asthma. What is that cardiac asthma?
Because of cardiac failure, there's pulmonary edema.
Okay.
Because of which the patient shows symptoms similar to asthma.
Okay. So asthma is an airway disease, whereas pulmonary edema is a problem outside the airway. There will be fluid accumulation. Can we use same NIV in all these breathlessness? So you have pneumothorax, you have cardiac failure, you have foreign body aspiration, you have asthma, you have COPD. All these things can produce acute breathlessness. So in which all conditions you can try NIV? Can you use it in asthma? Yes. Can you use it in COPD?
Yes.
Can you use it in cardiac failure?
No.
Yes. All the three conditions you can use. But can you use it in pneumothorax? No. What is the third one? Foreign. Can you use it there? No. So 2 condition it is very dangerous, but other 3 condition it can be tried. Okay. So we have put him on NIV. We have given you have given nebulization 3 cycles, but now he is improved completely. We have to discharge the patient. How do you discharge? How do you proceed?
So first,
you know that this is a case of asthma. So we have to confirm it, asthma, whether it is asthma or COPD, we have to confirm.
First send for FEV1.
Okay, so you ask for a PFT. In that PFT, FEV1 is one of the important parameters which will differentiate between asthma and COPD. What will happen to FEV1?
12.
Both condition it will be reduced. It will be less than 80%. But asthma, what happens? If you give nebulization, it improves. But COPD? It does not. It may improve slightly, but it does not improve more than 15%. Okay. So you can confirm your diagnosis. Okay. Then what you do?
Counsel the patient on how to use these metered inhaled dose.
Metered dose inhalers, that counseling has to be given. So, but what MDAs you are planning to give for this patient?
For MDAs?
MDA means metered dose inhalers. Okay. What MDA you are planning?
So, salmeterol.
So there are 3, I'll tell 3 important drugs. One is salbutamol, other one is salmeterol, third one is formoterol. All are having a beta agonist. Okay. What is the advantage of salbutamol?
Short acting.
It is a short acting, fast acting. Salmeterol?
Long acting.
Long acting, slow initiation of action. Formoterol? Fast initiation, long acting. So which is among these 3, which is best?
Formoterol.
Formoterol is the best because it can be used as a rescue drug, and it can be at the same time it can be used to prevent the further episodes. So suppose you are giving formoterol for this patient. Okay. So you are giving one patient salbutamol, you are giving another patient salmeterol, other patient, third patient formoterol. Salbutamol you are giving for a patient who is getting frequent episodes. Will it prevent further episodes?
No.
It will act immediately for 6 hours. It will act. So 3 times you have to give. Salmeterol you are giving and it will prevent the episodes, but when you get a breathlessness, what you have to give?
Salbutamol.
You have to give salbutamol as an extra drug for the treatment of acute episode. But if you are giving formoterol, no need to give a third drug, second drug. So formoterol can be used as a preventive drug and rescue drug. Okay. Now you are told about ipratropium bromide. What is that?
Ipratropium bromide
is a drug which is used in asthma and COPD. Both the condition it has been in practice for many years. Okay, but it cannot be given as a MDI. There you give tiotropium bromide. That's a different. Ipratropium is available, but it is a short acting drug. There also you have long acting tiotropium bromide. Should we give that? Is it required for this patient, or we can avoid?
We can avoid.
We can avoid because asthma is a large airway disease. COPD is a small airway disease. Salbutamol act in the larger airway, whereas ipratropium act in the smaller airway. So that is more useful in COPD than asthma, but we can combine, and many combinations are available. You can give that. Now you are told about magnesium sulfate. Is it really useful? Not useful? Can be given.
Magnesium sulfate is mainly an anticonvulsant, but what it does is it also blocks calcium channel blockers.
Okay.
So because of that, it might help in the relaxation of smooth muscles additionally.
So you should understand that it might help. It is not an indicated drug. If you want, you can give. It is proven that those who are receiving magnesium sulfate, especially in asthma and COPD, that prevents further episodes of repeated admission in the hospital. But it may not really help in acute situations. But we give in all patients to help them to prevent repeated episodes of asthma. Okay. So we had given salbutamol, ipratropium, and you had given magnesium. But any tablets can be can be given to this patient to prevent further episodes. Oral tablet. Steroids. So you had given 100 mg hydrocortisone. Now you can give oral prednisolone tablet. Okay. So it can be given 1 milligram per kg body. That may be 70 kg or 80 kg. Sorry, 80 milligram. That can be continued for how many days? How long he is having symptom? He can get one or two, 3 or 5 days you can give. Maximum up to 1 week you give, and then you stop it. There is no need to taper and stop it. You can just stop it. Okay. Can we give nebulized steroids?
That would lead to further infections in case he's
Okay,
under
that is not, it is not correct. What you told is not correct. In both in asthma and COPD, some amount of inflammation is there. If you continuously give oral steroid high dose, it will lead to infection. But if you are giving inhaled steroid like formoterol, budesonide, okay, that is a very small dose, micrograms. That will not create any infection. But both these conditions, it will be helpful. So somebody is having repeated asthmatic episode, along with your formoterol, ipratropium bromide or tiotropium bromide, you have to give steroid inhalers. Okay, so that can be continued. Then what else you told? Okay, any other oral drugs will be helpful in asthma, repeated asthmatic episodes?
Try out omalizumab.
That is a higher drug. For an MBBS student, one more drug is there in between. What is that drug? Leukotriene antagonist. Huh? What is that? Huh? Leukotriene antagonists are there. Okay. Montelukast. Leukotriene antagonist, Montelukast. That also can be tried. Somebody is having repeated episodes. That also can be tried. Now, what is your opinion about vaccination in this patient? Should we give vaccination or not?
Make sure he gets the flu vaccine every year.
Okay. So, anybody is having chronic respiratory infections or inflammation, it is better to give them vaccination, H influenza and pneumococcal. But H1N1 also can be tried, especially in elderly individual. Here, even if you don't give, nothing will happen. But it is better to give that. Okay. Now, what diet do you advise for this patient? Should we advise any diet or just let him take anything? You are giving salbutamol. He requires muscle mass to breathe with his to support his lungs. Okay. So what electrolyte imbalance can occur? Potassium deficiency can occur. So he need to take more potassium, or his good muscle mass is required. So high protein diet is always recommended for asthmatic and COPD patients. Whereas if we give high carbohydrate diet, what will happen? What is the end product of carbohydrate? I have already told. What is the end product of carbohydrate? Water and CO2. So CO2 retention can occur if you give high carbohydrate diet. You give high protein diet, that will be good for his muscles and everything. Okay, so high potassium, high carbohydrate diet. What else he has to do?
Make sure he does not have any gastritis.
Okay, so what is it? How gastritis produces asthma?
So the reverse
regurgitation. Okay, GERD. It comes regurgitate, and that acid will go to the lungs, and that triggers the asthmatic episode. That is one of the common cause for asthmatic episodes. So you can give pantoprazole, domperidone for a short period. What should be his position? Is suppose he has such history of aspiration and trigger of asthma. What should be the position? This will be the best position. This will be the best position. So propped up position is very important for all patients who is having aspiration. And when the patient is taken inside the hospital, most of the time we forget to give the patient in propped up position. We have to always keep the patient in propped up position. So can we discharge the patient right now?
Right now, no. First, after his FEV1, all the tests
So we
are
have to
done.
do a pulmonary function test. We'll do that. Then we can train him for MDIs, and something called as spacer. Have you
Yes.
seen spacer?
You keep it in between.
Okay, what is the difference between taking meter dose inhalers directly and with the help of spacer?
The spacer helps directly. Helps the drug directly enter to the airways.
It's
instead
not exactly. So when you press the MDI, you need to have good synchronization. Press it, take the breath inside, hold it. Okay, but suppose the patients are not able to do that exact method, so you can advise them to give a spacer. Okay, spacer will be like a tube. You press the medicine into the tube, it will not stick on the walls of the tube, and whenever patient want to take the breath inside, they can easily take it inside. That is advantage of spacer. Now, how do you differentiate cardiac? We had discussed about cardiac asthma and the actual asthma, respiratory asthma. How do you differentiate these two? Can you differentiate these two without any help of echo, cardiologist, pulmonologist in emergency room?
Auscultation.
Eh?
On auscultation.
Auscultation, predominantly it will be crepitations with V's, cardiac failure. Here it will be more of V's. What else? Any investigation will
Chest X-ray.
Chest X-ray will show bilateral extensive shadows in cardiac failure. That may not be there in asthma. Any blood investigation? BNP. What is BNP? Brain natriuretic peptide. That can be elevated in cardiac failure. Okay. So you understood how to manage an asthma case in emergency room. Now can we discharge the patient?
Yes, sir.
Yeah, if you have treated well, we can discharge.
Yes, sir.
If you are confident, we can discharge. Yes or no?
Yes, sir.
So you are confident, we will discharge the patient.
Thank you, sir.
Okay.